Professor Berthold Koletzko to the stage to talk to us about early childhood nutrition and obesity. Professor Koletzko is Professor of Pediatrics at Ludwig Maximilians University in Munich. He's also President-elect of, now let me get this right, the European Society of Pediatric Gastroenterology, Hepatology and Nutrition. Prior to that, he traveled the world and worked in many children's hospitals, with his main focus being on metabolism and nutrition. He has contributed hugely into research in this area and has won many awards in this respect. Welcome, Professor.
Thank you very much indeed for the very kind introduction. And thank you to Professor Dawan and the organizing team for giving me the privilege and great pleasure to participate in this exciting meeting. My topic here is on obesity, a problem that seems to overwhelm us, and we become as frustrated as our patients because we have so little we can do to reduce obesity in children and adults alike. The surgeons promise to us they have the solution. They just cut and the obesity is gone. But then, of course, they don't really look at the long-term problems that remain after surgery. We have a real challenge here, and the good news is, in early life, we can do something about it. And that's what I would like to share with you. So you heard already, I work in Munich in Germany, and while it looks nice on the picture, I can tell you it's very cold there now, so it's a great privilege to be in Abu Dhabi today. My learning objectives, I think, are in the program. I would just like to share with you a little bit of the idea that what happens in early life has an impact on long-term health, and show you that breastfeeding provides benefits for obesity risk, and we know now at least one of the mechanisms how breastfeeding works, and that is the protein supply with breast milk, and we can imitate that in infants that are not breast milk. So that's what I would like to discuss: obesity, the concept of early programming in the perinatal period, the role that rapid postnatal growth has for later disease risk, the protective effect of breastfeeding, and the impact of reducing protein supply to infants in terms of metabolic and endocrine response, effects of obesity, and a word on safety. So I don't tell you any news if I share this map on obesity prevalence around the world, and this part of the world, as you know, is one of the hotspots really where the obesity rate is terribly high, and along with it, the rate of diabetes and other disorders. And that's why we're really concerned about obesity. It's not so much about bigger closes, it's about insulin resistance, diabetes, and a lot of associated health risks. We just heard even prenatal diagnosis becomes more difficult from Dr. Nicolaitis in obese women. We have a lot of adverse outcomes at birth, both on the mother and the baby. In obesity, we have more cardiovascular disease, musculoskeletal problems. We have basically a shorter life and a poor quality of life associated with obesity. World Health Organization says that today, obesity and the consequences of obesity are already the 5th leading cause of deaths around the world, accounting for almost half of the diabetes in the world, a quarter of ischemic heart disease, and a significant portion of cancer burdens, both colonic and mammary cancer being associated with obesity. And here again, diabetes prevalence. Wow, you're really top of the pops in diabetes, apparently, according to this map. So that's bad news. Why then do we have the problem? Why do people become obese? You can look at the literature. You find a lot of complex confusograms on that, but actually the answer is simple. In 1980, when we were always slim, our TV sets were massive, and now that we have flat screens, we've become obese. And obviously, physical activity really is a key factor for obesity. Physical activity is a strong protective factor, and that's what we try to emphasize in pediatrics a lot. So yes, environment matters. for the risk of non-communicable diseases, obesity and the related diseases. And then genes, we were told, are terribly important. Genes are terribly important for our risk to become obese and to die from diabetes. We were all excited when the human genome came about. Millions of dollars were spent, and people thought this is the solution for our common diseases. But if you look at genotyping, for example, in this study, 33,000 adults across Europe, 15 cohorts, that picks up all these signals for risk of obesity, particularly the FTO gene, the most powerful gene we know today for human obesity. How much of obesity risk is predicted by genetics in that population? 33,000 Europeans. What's your guess? 10%, 30%, 50%, 80%? Well, it's less than 1% of BMI variation, less than 1% that is predicted by genes alone. So genotyping people will not help us target risk groups and identify people who are at high risk of obesity, except for the small number of people with monogenetic forms of obesity. Genes alone don't do it. But what we've learned is that there is environmental factors that modify the effect of genotype on phenotype, including nutrition during sensitive periods of developmental plasticity, the first 1,000 days, pregnancy in the first 2 years of life, where there is a lot of epigenetic modification of our genome in predicting our phenotype. It's a fascinating story, and I don't have time to go into the details, but basically what it says is what Hillary Clinton has promoted so much. During the first 1,000 days of human development after conception, we have a window of opportunity where environmental cues, including improving nutrition, have lasting effects on determining our physiology and function, our health, and long-term disease risk. So that's exciting news, and it tells us we better try to understand this better and focus on the implications for public health. So in addition to environment and genes, we now have early programming on the map if we want to improve public health. Now you all know of the fascinating studies by Nick Hales and David Barker that associated low birth weight, slim babies with an increased risk of later disease in retrospective epidemiological studies. Now that has really pushed a lot of investigation around the world to try to understand what these associations are based on. With association, we always wonder, is it causal, or is it like this proof for global warming? Association alone is not really giving us scientific evidence. So that's why the European Commission has decided to invest real money into looking into this to provide a better evidence base, prospective epidemiological studies, mechanistic studies looking at the underlying causal mechanism, and also randomized controlled intervention trials in pregnancy and in early life, which are really key for establishing the scientific basis for preventive intervention. This is the early nutrition project that we are privileged to coordinate in Munich, and it brings together researchers from 36 institutions across Europe, the United States, and Australia, and of importance, it's really across all kinds of disciplines that work together to look at this concept. Do metabolic modulators in pregnancy and in early life during sensitive time windows of developmental plasticity, change cell development, organ development, metabolic and endocrine response, and the epigenetic regulation of gene expression, and thereby induce early metabolic programming of lifelong health. We follow these three key hypotheses in the project. We look at the impact of fetal overnutrition, the fuel-mediated in utero hypothesis, in other words, the concept that in maternal diabetes, in maternal obesity, There is an increased flux of substrates across the placenta, more glucose, more fatty acids are transported to the fetus, the fetal growth trajectory is changed, there's more body fat deposition, and that leads to a lifelong increased risk of adiposity, visceral adiposity, insulin resistance, and so forth. The second hypothesis we follow is the accelerated postnatal growth hypothesis. Enhanced postnatal growth by overfeeding, short breastfeeding, excessive protein supply increases late adiposity. And I'll focus in on that hypothesis and share with you some evidence for it. And thirdly, the biggest killer of all, apparently, is the mismatch hypothesis. If you have slow intrauterine growth, low birth weight, and then rapid postnatal growth, a pattern that you find nowadays in many underprivileged populations across Asia in particular, where you have high rates of low birth weight, rapid postnatal growth, and rampant rates of diabetes. So that is something that globally really deserves more attention. So as I said before, we are looking in the project at mechanisms, at prospective observational studies in concurrent populations, and at randomized intervention studies to test these three hypotheses with the ultimate goal to devise recommendations to improve health. Now let's look at the accelerated growth hypothesis. For this, we have a lot of observational support from observational data, as shown in this graph, looking at a number of studies around the world that have associated high weight gain in infancy in the first 2 years of life with an increased risk of obesity in adulthood. I'm not sure whether I can ever close this here. Yes, I can. Good. Okay, so all these studies have included children that had a growth 2/3 of the standard deviation above the mean. In other words, it's basically 1 percentile channel higher. And you see that consistently, those children who grow fast early have a higher risk of obesity in childhood, in adolescence, and in adulthood. If you look at the total adjusted risk of obesity later, it's doubled if you grow fast. And Nick Stetler in Philadelphia has actually concluded, based on observational data in the United States, that in the US population, rapid growth in the first 2 years of life, or actually in infancy in his study alone, would explain 30% of obesity risk in the United States population. That's huge. That's huge. And if confirmed, it would give us a golden opportunity for obesity prevention in early postnatal life. Well, rapid growth can be due to feeding, but it could also be due to other factors. So is it really something that is modifiable, or is it already predetermined by genetic and other biological factors? Well, we have data to support that nutrition is important. For example, this small but well-conducted study in the United States that looked prospectively at infants that were breastfed or bottle-fed. And you see here the evolution as weight expressed as standard deviation from the mean. And you can see that during the first 3 months or so, breast and bottle-fed babies grow pretty similar, but then in California, the breastfed babies stay significantly leaner than the bottle-fed babies, significantly different from 7 months onwards, much different at 1 year, much different at 2 years. So if you have seen the previous one, if rapid growth is associated with more obesity, you would predict breastfed babies should have less obesity later if they grow slower, right? And indeed they do. This is a large study that we did 15 years ago already, where we looked at 9,000 children in southern Germany, in Bavaria, and looked at their overweight and obesity prevalence at school age, and related that to early feeding, adjusted for all kinds of confounders, socioeconomic, birth rates, smoking in pregnancy, what have you. And you see that consistently, yes, there is a reduced risk in the children who have ever been breastfed compared to those who have never been breastfed. Overweight is 20% less likely if you were breastfed, and obesity at school age is 25% less likely if you were breastfed. Well, that's impressive, I thought, but then even more impressive is that we have a dose-response relationship. The duration of breastfeeding matters. The longer the children are breastfed, the lower is the risk of obesity at school age. So that is, of course, compatible with a causal relationship if we have a dose-response effect. But Bavarian people are very strange. They dress in these strange clothes with short shorts from leather, and they drink beer all day long, and they never work. So you would say, is this really important for Abu Dhabi? Is this reproducible in other populations? And yes, it is. A number of meta-analyses have been performed with studies all around the world. This is an early one that we performed. You see 22% reduction by breastfeeding. Later ones show the same effect, but different effect sizes. One says 15%, one says 24%. So yes, there is a consistent, perhaps modest, but consistent protective effect associated with breastfeeding on later obesity. That's great. It would encourage us to enhance our efforts to support and promote and protect breastfeeding. But there is a caveat, of course, that these are all observational studies. None of these studies has really randomized breastfeeding. You can't randomize breastfeeding. So we are not 100% sure how much confounding is there in this protective effect. Anyway, we would follow the model of the ancient Latin Americans and say, let's try our best to promote breastfeeding. Nonetheless, in every biological effect, there are exemptions. And this is a case that we observed where there was really an explosion of weight gain of this child during the period of the first 5 months when the child was exclusively breastfed. This is a normal percentile growth, and this is this child that was born heavy and then during full breastfeeding has exploded in weight. And many of you may have seen such children. So it's not foolproof. Even with breastfeeding, you can have excessive weight gain, and you would expect then a long-term increased risk of obesity. Now, why is this? In this particular case, we were doing all kinds of tests here and thought this must be a monogenetic disorder. It must be leptin deficiency, melanocortin 4 receptor deficiency, something rare. But then when this child stopped breastfeeding or full breastfeeding and had complementary feeding introduced, growth leveled off. And the child became more close again to the 97th percentile. So it had to do with breastfeeding. Therefore, we analyzed breast milk in late lactation, and we found that everything was normal in the breast milk except for protein. Protein was 1.5-fold the norm in this mother's breast milk. This mother produced a milk that had an unusually high protein content, where all other factors were normal. So it raises the question whether protein matters for rate of growth. And in fact, that is a hypothesis that we followed, the early protein hypothesis, considering that excessive protein intake in infancy could promote high weight gain early and increase the risk of later obesity. Oops, it's the wrong way around. I'm doing it the wrong way, sorry. So we looked at formula feeding and bottle feeding before, and we saw that formula-fed babies grow faster than breastfed babies on average. And in fact, with conventional formula, we have given much more protein than with breast milk. This is a German study where you can see that the median of protein intake in bottle-fed babies compared to breastfed babies at 3 and 6 months is 55 to 80% higher, about 1 gram per kilogram of protein more in bottle feeding as compared to breastfeeding. That's a big difference. And we thought maybe, yes, that might matter, because if you provide a lot of protein, we thought maybe you increase the concentrations of insulin-releasing amino acids in blood and tissues and thereby induce the secretion of growth factors of insulin like growth factor 1, and thereby induce enhanced weight gain, enhanced adipogenicity, and a long-term increased risk of obesity and associated disease. And there is a lot of biochemical basis for this. I don't want to confuse you, but just want to mention that there is a sensor in each and every one of our cells for nutrition and environment, which is called mTOR, mammalian target of rapamycin. And this sensor is basically our detector for whether we have eaten this morning or not. If we have eaten and we have high concentrations of amino acids like leucine in our blood, mTORC2 will be detected, and if we have these concentrations there, we'll switch to anabolism in children to growth. And along with that, also the growth factors, insulin, IGF-1, have the same positive stimulating effect on mTORC2, whereas both low energy and hypoxia will downregulate. So that's an interesting concept. Our body knows how our metabolic state is, and thereby switches growth on and off. Now, how do we know whether early protein matters? Observational studies can't tell us the answer. We need to do an intervention study to really prove causality. So we applied for that to the European Commission. We got funded and did this randomized controlled trial in 5 European countries, enrolling almost 1,700 healthy babies with a birth weight between the 10th and 90th centile. We had a reference group that was breastfed, given about 1 gram protein per 100 milliliters of breast milk. And we had formula-fed babies, which were randomized double-blind to receive for the first year of life either formulas with conventionally high protein, 2 grams in the infant formula, 3 grams per 100 milliliters in the follow-on formula fed after introduction of complementary feeding, or an experimental arm with reduced protein, more similar to breast milk. Infant formula was 1.25, and follow-on formula was 1.6 gram per deciliter. The children were given these formulas, as I said, for the first year of life. Then the intervention stopped, and the children were followed up. At 6 years now, we've been able to follow up about a bit more than 60% of these children, get their weight and length at 6 years and calculate their body mass index, and I'll show these data to you in a couple of minutes. So these were the 5 centers across Europe, so I think it's pretty representative for a European population. Of importance, the intervention we did was not very different from standard practice at the time when we started the study. We had study products with 1.8 and 2.9 on the market. Families bought products between 1.8 and 2.6. Follow-on formula pretty much the same as well. So it is not an extreme intervention, it's an intervention that is representative of what actually happened at the time when we started the study. By design, we provided a different protein intake, and you see, again, the difference is similar to what I showed you before between breast and formula, about 1 gram per kilogram per day difference between the 2 randomized arms. And the difference becomes smaller with increasing age because the children get more and more complementary feeding. The role of formula becomes less. After the intervention, there was no difference anymore. The 2 formulations were equal in energy content, achieved by a small adaptation of the fat content, and therefore the energy intake of the 2 arms was not different at all. And as you see here from the comparison with reference intake of World Health Organization, United Nations University, the lower protein group is not a low protein group. It still provides much more protein than children need to meet their requirements. Now, you saw our hypothesis. We thought insulin-releasing amino acids would go up with high protein. Yes, they do. The difference between high and low protein arms is significant for all the essential fatty acids, essential amino acids. They all increase. For the indispensable amino acids, the picture is more varied. Why is it that we have such an increase of plasma amino acids? Well, this is particularly relevant for the branched-chain amino acids, valine, leucine, isoleucine. These are the branched-chain amino acids, and they are important because they're not only substrates, they're also signaling molecules. Whereas most amino acids are metabolized in the liver after absorption, a significant portion of the branched-chain amino acids escape the first-pass metabolism, and they're only oxidized in the muscle. And therefore, in the general circulation, BCAA, the branched-chain amino acids, functional signaling molecules. They are the key drivers for our energy sensor for mTOR, and they tell our body what to do. So they really go up, and they go up because, and that's really a novel finding, infants have a limited capacity to catabolize these branched-chain amino acids. We did this ratio between the branched-chain amino acids and their catabolites, and you can see that for a while there's a linear relationship between the amino acid and its catabolite, and then at a break point the relationship stops. In other words, there is a threshold reached where the infants cannot anymore catabolize these amino acids. And with the protein intakes that we have given in the past, we have exceeded the threshold and therefore exponentially increased these signaling molecules in the body. And interestingly enough, pretty much the same breakpoint we find for the synthesis of urea. So also the synthesis of urea reaches a saturation point, a point where infants cannot form urea anymore in a linear fashion. That should be a warning sign for us. We don't want to give to babies a protein intake that exceeds their metabolic capacity. So this is what's happening with increasing levels of protein supply to babies. At some point where the metabolic capacity is exceeded, the branched-chain amino acids in blood will go up exponentially. The signaling effects are increased. So it would appear prudent not to provide protein that exceeds that threshold. The second part of our hypothesis was that we enhance the growth factors, and yes, we do. You can see there's a significant difference here in plasma IGF-1, along with the binding proteins, and also in insulin secretion measured here by urinary C-peptide excretion. With lower protein, we reduce insulin and IGF-1 formation in these babies and becomes closer to the reference group of breastfed babies, although they are still higher in the lower protein group than the breastfed group. So breastfeeding clearly is still superior in that marker. That's great. The question is then, how relevant really is nutrition? Is it not all genetics? So we genotyped these children and looked at the impact of genetics on IGF and the binding proteins, and you can see for the total IGF, this important signaling molecule for our growth, genes explain about 4% of the variation. So yes, it matters what genes you have. Gender also matters, about 1.5% of the population, not surprising. We know boys and girls grow slightly differently. So how is that in relation to feeding? Well, genes are pretty irrelevant compared to nutrition. Genes explain 4%, nutrition explains 15% of the variation of IGF-1. That's great news. We have a real opportunity here to modify growth by feeding. And that matters because serum IGF-1 is a significant predictor of weight gain velocity at 6 months, 12 months, 24 months. So with this metabolic regulation, we can modify weight gain velocity. And that again is important because weight gain velocity, as we measured with isotope dilution, is a very strong predictor of body fat mass and body fat deposition. So the more IGF-1 you have, the fatter your baby gets. And we have an explanation, metabolic explanation. I know that this is complicated, but we are so excited about this that I can't stop telling you about this. With higher protein, we reduce fat oxidation and we push fat to body fat deposition. This is a ratio of acylcarnitines to free carnitine, which shows you sort of the initiation of beta oxidation of fat in the body. And you can see it's higher in breastfed babies, slightly less in the low protein group, and significantly less in the high protein group. So what this tells you across all these metabolites is with high protein, there's less fat oxidation, and more fat, if you don't burn it, is then put into your adipose tissue. that actually translates into growth. Here you see the evolution of the body mass index from infancy to school age in our children. You see in yellow here the breastfed group, the sort of normal growth of babies. You all know these BMI curves. Children increase their BMI in the first year, then go down, and then at some time in early childhood increase again. Now the children who get conventional infant formula have a very different growth pattern. Their BMI increases much more in the first year, up to the first year of life, still significantly higher at 2 years, and then has an inflection upwards earlier than the breastfed group, with the result of being much heavier at 6 years than the breastfed group. This is what we've seen before. Breastfed babies grow slower and have less obesity at school age. Now, what about the low protein group? Well, the low protein group also in the first year grows slightly different, slightly heavier at 1 year, but from 2 years onwards, the body mass index is the same as a breastfed group. So that's exciting. We have, with just a slight modification of infant feeding, a normalization of infant growth up to school age. Body mass index is normalized just by modifying for protein intake. The effect size, on average, is half a BMI point at 6 years. Now, does this matter? Well, it's a lot, half a BMI point. If you look at the recent Cochrane review, what approaches to obesity prevention can achieve, 55 studies, the mean BMI effect is only 0.15 kilogram per meter square. With reducing protein, we can achieve 3 times as much. We can achieve 0.5 BMI points, so it's really worthwhile. And even more important, the effect is huge at the high centiles, our high-risk group. If you look at the 90th centile, 1.5 kilogram per meter square, at the 95th centile, 2.5 kilogram per meter square. And that translates into the rate of obesity. If you look at obesity, percentage of children at 6 years, and conventionally bottle-fed babies, it's 10%, and breastfed babies, it's 3%. A lot of difference between bottle feeding and breastfeeding. Now, if you look at the randomized comparison, the low protein group, we can go down to almost 4% by something as simple as reducing protein in infant formula. An intervention that doesn't cost money, that doesn't need any lifestyle changes. It's far more difficult to tell families, switch off the television, get rid of those sugar drinks, give your children more fruit and vegetable, make them go out and play. You all know how difficult that is. But changing to an improved formula quality is very straightforward and doesn't even cost money. So if you look at the risk reduction adjusted for confounders, is 2.9-fold less obesity with improved infant feeding that can be achieved. A huge effect size. There's other effects that I think is also potentially very relevant. For example, renal growth is markedly affected by way of infant feeding. If we reduce protein intake, we can get much closer to physiological growth of the kidney in the breastfed group, and that may be important for long-term health. We know breastfed children have a lower blood pressure in later life than conventionally bottle-fed babies, so perhaps this modification of renal growth has also further impacts that we are interested in following up. You may ask, is it all safe? Well, we've gone through a lot of trouble in doing very complex neuropsychological testing at 8 years in these children with a huge developmental test battery. And these data, which are now in press, basically show that there's no difference whatsoever in anything that we have tested between higher and lower protein. So providing less protein during this sensitive period of rapid brain growth and development has no adverse effect. And perhaps you would have predicted that because we, again, don't give protein malnutrition. We still give a lot of protein, much more than the breastfed babies get, but it's safe in everything that we can measure, including neurodevelopment. So my take-home messages are pretty simple and straightforward. I think we really need to limit protein supply to infants. We should promote, protect, and support breastfeeding because it reduces later obesity risk, and I think our study has strengthened the evidence base that breastfeeding has a causal effect. We should avoid high protein supply in all babies. Infants that are not fully breastfed should get an infant formula today with less protein, closer to breast milk, but high protein quality. And in all infants, we should avoid cow's milk as a drink, unmodified cow's milk as a drink, because cow's milk has 3 times as much protein than breast milk or modern infant formula, and we really boost protein intake and obesity risk if we give normal cow's milk as a drink to babies. Now, I would like to thank you all very much indeed for your attention. I would like to thank a wonderful group of colleagues and friends that I'm privileged to work with, and of course all the families that volunteer in participating in these rather demanding studies. If you want to know more, come to Munich in October 2016, where our EU-funded project, the Early Nutrition Project, will organize an international conference, The Power of Programming 2016, looking at the latest evidence in this whole area of programming in pregnancy and in early childhood. Project earlynutrition.eu gives you all the information. If you don't want to wait that long and want to get some more information today, then switch on your iPad or your computer tonight and go to earlynutrition.org, where you have a free CME accredited platform for online learning, very interactive courses on nutrition and pregnancy, on breastfeeding, complementary feeding, and infant formula feeding, more coming soon. And this part of the world actually has a lot of users. We have now 4,500 participants almost from all across the world. And interestingly enough, the Middle East is a real hotspot where people apparently really enjoy looking at this form of learning. So go online, earlynutrition.org, and try it out and share it with your friends. Thank you very much indeed.
And in the hospital I work in, 1 in 5 of our patients have gestational diabetes or diabetes. How do you think that might be contributing to problems with obesity and nutrition in childhood?
Thank you for this important and insightful question. Yes, the evidence is there. Clearly, if there's maternal obesity, maternal diabetes, the long-term risk for the offspring is markedly increased. There's a lot of questions regarding the mechanism. The simple mechanism I try to allude to, higher substrate supply. If you look closely, there might be other factors involved, inflammation, leptin, other factors as well. So the biology might be more complex than just substrate support across the placenta. The important question from the clinical side, of course, is what can we do about it? For gestational diabetes, there is, of course, strategies for early identification and for intervention. I think it needs to be looked at more closely. What is the best strategy? For obesity, the Institute of Medicine guidelines have focused on gestational weight gain, and across the world now, clinicians are really hooked to looking at gestational weight gain. But it's all based on observational studies. There's very little hard evidence from intervention studies here. And also, if you think about the patient, it's very difficult to use gestational weight gain as a therapeutic goal because it is not really something that the woman can directly influence. The observational data lead us to believe that weight at conception, BMI before pregnancy in the first trimester is actually a much more powerful predictor of risk than gestational weight gain. The other important finding, I think, is a result of the LIMIT study in Australia, where they included more than 2,000 overweight pregnant women and randomized them to standard care or a lifestyle intervention that was very simple: improving physical activity, enhancing physical activity, improving dietary quality, less sugar, less saturated fat, with 3 consultations and 3 phone calls, something very realistic. It did not change gestational weight gain at all, but it reduced birth weight above 4 kilograms by 20%. And that's important because birth weight above 4 kilograms increases long-term obesity risk twofold. So our focus on gestational weight gain maybe needs to be challenged, and we need to look at something that is more realistic for implementation in clinical practice.
Thank you very much. And I just have one question. You mentioned the difference between the bottle-fed, different concentrations of protein, and the breastfed as a one group. Does it differ how the mother is getting her nutrition, whether this is optimal or not? Because I got to know that lactation consultants are now advising less protein intake for the lactating mom, depending on these studies. So what do you think?
Thank you very much. Yes, that's an important question. Maternal diet matters for breast milk composition in a number of factors. For example, milk lipid quality is changed by maternal intake. If the mother has a regular supply of oily fish, then the level of omega-3 DHA in breast milk will go up, which is considered to be beneficial. For protein, it doesn't matter. Protein in breast milk and lactose in breast milk is not really influenced by maternal diet unless you have severe malnutrition. So to advise women to eat less protein in lactation is not useful.
What we're talking about is interventions in pregnancy, throughout pregnancy, to keep women healthy and eating better. But Professor Nicolaides was talking about inverting our old style of doing antenatal care with regular visits as pregnancy progresses, and rather concentrating, turning the pyramid round. Those two things don't match.
I don't think there's a controversy here. The question, though, is pregnancy the only time that we should think of? Is it not the time before pregnancy that really is an opportunity, starting already in adolescence, in adolescent girls, and trying to promote healthy behavior? If you want to change an obese woman to normal weight in the 3 months at the beginning of pregnancy, you don't have a huge opportunity, and perhaps you should think of adolescence and pre-pregnancy just as well.
The concept of the pyramid really is to emphasize to people that we need to intervene in the beginning rather than let pregnancy carry through with these 4 weekly visits. The emphasis, well, we are doing a randomized study now on metformin, starting from 12 weeks. We will see whether that will reduce the prevalence of macrosomia or not. I fully agree that at the end, you need to enter the pregnancy in a better condition than before. But the question is whether that is achievable or not. What do you think will achieve that? Better education? Because why are we, on a worldwide basis, having this exponential increase in obesity? And my worry is that the sort of Marie Antoinette type of attitude, or 15th century approach towards helping Africa from Western countries. In reality, the problem of obesity is a problem of poverty, isn't it? We can concentrate in Munich, in the upper middle classes, and send them to the gym, and in London send them to Harrods to buy organic food. But actually, the vast majority of the population that are going to contribute to this problem are poor. And we are not going to change that, are we? We're going to give them McDonald's. Is the McDonaldization of poverty, obesity for me?
As you know, pediatricians are optimistic people, and I'm perhaps less fatalistic in that respect, and I'm optimistic. Yes, indeed, education is the key predictor of health in many aspects, including obesity and associated disease. So we would all want to enhance education and tell our governments this is where you need to invest and focus on the underprivileged groups in society. Absolutely. But it's not the only aspect. We can do something. I'll give you one example. There is a project looking at preschool children, was done in Germany, was done with the European Union in 8 European countries. Going into preschool education, into daycare centers, and having a very simple behavior program to enhance physical activity, make children drink water, make children eat fruit and vegetables on a daily basis. It was extremely cheap. In Germany, it cost €2 per year per child, almost nothing. After 1 year, the average of overweight in the cluster randomized control was 18%. In the intervention, it was 14%. And what's more, it was not only effective in the whole group, it was particularly effective in the migrant population in the low socioeconomic group. I think it depends on the approach. If you give out brochures, if you tell people in the consultation, do this and this, it's not going to work. If you do a behavior changed approach, particularly at an age where behavior is still modifiable, with a little investment, you can change something. There's other examples. If you really make it more difficult, less accessible to have sugared drinks available for children, for example, you can change overweight rate by just kicking out sugared drinks out of school. That has been shown in randomized trials. You reduce obesity. So I think we have elements. We need to refine it, but I don't think we have reason to be complacent and lean back and say we cannot do anything.
Is the rate now going down?
Well, we have school health examinations at school entry at the age of 5 to 6. And we see that over 15 years, overweight and obesity was going up. And now we have reached a level of the curve and it's slightly going down at 5 to 6 years. It's still high, higher than in the 80s, but at least the trend has been stopped and we are slowly moving to a lower prevalence. And I think it has to do with more public awareness, with activities that have been implemented. We still have fast food, we still have lots of sugared drinks, we still have sedentary behaviors, children spending hours and hours a day in front of the screen. So we still have lots to do, I think, and we still have a lot of disparity between rich and poor, which is, I think, a huge challenge to address. But the development shows that improvements can be achieved. Well, Greece is one of the champions. Interestingly enough, the Mediterranean countries, all the Mediterranean countries, Greece, Italy, Spain, Portugal, have the highest rate of childhood overweight, about 1 in 3 children. In the north of Europe, it's lower. The UK also sticks out. The UK has 27%, I think, at 11 years. So it's Southern Europe and the UK, for some reason, that have high rates of obesity. Otherwise, there's a north-south gradient, the lowest levels in Scandinavia, the highest in the south. And I can't explain why that is. I really don't understand it. But it again shows that there is apparently environmental factors, modifiable factors that can be approached. And if you think about the pregnancy where we started from, where in the UK I think you have now 1 in 4 obese women in that age range, obviously it's going to be too late if we try to start changing body mass index at 25 or 30 years. We have to start in childhood and adolescence if we really want to change the population.
My question is to Dr. Professor Koletzko. If we take the argument about the protein and it can be a cause of obesity, on the reverse story, if we have children with malnutrition or with failure to thrive, should we make sure that, or encourage our dietitians to make sure that they give high protein rather than just adding DUCAL or MCT fat to the feeds if we want to increase the weight?
Thank you. That's an excellent question. Obviously, we need to provide enough protein to meet needs. And if you have a child that with catch-up growth that needs to grow faster than the normal growth, we also need to give more protein. However, if you calculate that, after the first months of life, the usual protein need is about 5-6% of energy, and even with the fastest catch-up growth, you never need more than 10% of energy as protein. Now, if you look at your enteral nutrition formulation and so forth, they always provide 10% or more, usually 15% of energy as protein. Our diet that we usually eat always provides 10 to 50% of energy. So protein is hardly ever the limiting factor for catch-up growth, except in very poor conditions. But even if you look around the world, in all the studies on childhood nutrition, it's only Bangladesh, the only country in the world where children under 5 have a protein intake that's just about at the limit. All over the world, even the poorest population, protein intake is higher than the protein needs. It's not limiting.
My question is about obesity in children. I work in Kuwait, which has the same environment, the same as UAE. Most of the time, most of the year is hot, so children stay at home or indoors and are addicted to screens. So we have, the figure in diabetes, type 2 diabetes in children is quite high in Kuwait compared to the rest of the world. And this is mostly due to obesity. So we have a high obesity rate in Kuwait in children, plus the adults, of course. So mothers, I'm sure that mothers want their kids to be healthy. They want their kids to be normal. But because of lots of things, confounders, they cannot make it. So now we are in the era of bariatric surgery. So many adults go to bariatric surgery to get their weight, normalized, and also children. So we have kids now, 14 and 15 years old, who are subjected to sleeve operations, gastrectomies, and bypass operations. And this number is getting worse and worse in my country. So what is the trend in, I'm sure that in Europe, you have some legal or, some laws that are against getting kids to bariatric surgery. But in my country, unfortunately, we haven't reached this stage. So why do they suffer now? Let them eat, and when they reach 15 years old, or 16 years old, they will go to gastrectomy. As simple as that.
Well, that's a complex topic. Our concept is that we use bariatric surgery in adolescents that have reached final height and where all other modes of treatment have failed, and who have morbid obesity, who either have excessive BMI 35 or more, or who have type 2 diabetes or other comorbidities where you really need to act. Bariatric surgery works, but it doesn't solve the problem. It's not the solution for everything. So yes, BMI goes down, but problems remain. And to believe that eat as much as you can and then just go to the surgeon and the problem is fixed is a bit short-sighted, because if you look closely at patients after surgery, a lot of problems remain. So yes, we need bariatric surgery at this time, but in a way it's an indication of our failure to effectively prevent and treat. And we really need to invest more in developing better treatment, where we have a long way to go, and in prevention. Now, in your case, in Kuwait, there is probably a lot of things that one would need to look at and explore at the societal level. How can you enhance having fun with physical activity in schools, in the school system, and in other aspects? What can be done to limit screen time and encourage children to look at other things? And thirdly, what can be done to reduce energy density of drinks and foods? That would be sort of the key elements. But I agree it's going to be very difficult for the individual family if they don't have support from the whole societal approach.
Okay.
The other concern that I have is we see a lot of families from the Arabian countries who come to Munich in the summer for their holidays and then have a medical checkup. And I keep hearing from families, yes, but a slim child is either poor or sick. There is a perception it's wrong to have a slim child. If your child is a little bit more chubby,